Good evening, all the aspirants present here. The next crash course session will be taken by Dr. Avishek sir. Thank you, sir. So you may start.
Okay, so I guess that this is a crash course session, and then we'll discuss few based on the questions. The DK, that is diabetic ketoacidosis management, which of the following if a diabetic patient presents with blood sugar of more than 200 with a bicarbonate of less than 15. Number two is that if the ketones increase, then it indicates more severity. Number three should be treated with fixed dose insulin infusion. Four, during management, subcut insulin is started if sugars are controlled on IV insulin, usually 2 to 3 hours after the IV insulin. And progression can be monitored with urine ketones. So what are the options? I mean, I'm expecting true and false options. True and false. So it's, I mean, you can answer in which of the following is true. Okay. Let's see who are right. As of now, I'm getting few options. Actually, no. I think one option only. Someone only has answered. So this question, actually, the correct answer is three. That is, should be treated with fixed dose insulin infusion. When there is the presence of hyperglycemia, that is, as per the traditional definition, sugar should be more than 250. Although yes, the current JBDS does say that 200 above is also accepted. Ketones bodies has to be positive and bicarbonate less than 50. So ketones has to be positive either by urine stick, but more than +2, or blood ketones, that is more than 3 millimoles per liter. So option A is incorrect. Option 2 is ketone does not indicate the severity. It is only indicates the lack of insulin, but the severity is dependent on the pH. So there is a classification of diabetes. If you go and read that, it is dependent on the pH, the bicarbonate levels, and the clinical scenario. So that determines the severity, not the ketones only. Should be treated with fixed dose insulin infusion. That is actually correct, because whenever a patient with DKA comes, you tend to start off with a 0.5, 0.1 units per kg of insulin stat, followed by 0.1 units per kg per hour infusion. So it's a fixed dose, right? So it's not a typical ICU patient where you manage as per the sugar requirements, you divide by 100 or 150 and run the infusion. So in this case, it is actually true. During management, subcut insulin to IV to subcut insulin switchover is dependent on the resolution of acidosis. Whenever the anion gap closes, patient is about to eat, then only the switchover occurs. If the anion gap is open, you cannot switch over to subcut insulin. Regular subcut insulin you cannot switch over to. And progression cannot be monitored by urine ketones because they tend to be positive for more than a week. So only the blood ketones has to be corrected. So this is the based on few of the conceptual things. Which of the following are complications of decay? So which of the following are complications? Known following complications of decay. So if this is an open-ended question, so it can happen that the patients can have any answers per se. First, I'll take some answers, quick 30 seconds, and then I'll go for discussion of the individual components. So this is actually a multiple choice question. Almost based on different exam scenarios where sometimes multiple choices are correct. So which of the following is correct? Is everyone audible? Not getting any answers. Okay, so I'll decipher this. Okay, A and B, someone told. Okay, A and B both are correct. And you have fourth option that is also actually correct. So except for 3 and 5, you can have everything. So you can have a insulin mediated hypokalemia and hypomagnesemia during a rapid correction of blood sugars. If your blood sugar is above 600 and if you're correcting very rapidly, so your osmolality can change in the brain and it can lead to sudden onset cerebral edema, especially in the young patients and neonates. So not neonates, but the young children. So that's why cerebral edema is also a complication. Hyperphosphatemia is rare. You can have hypophosphatemia. NAGMA, that is due that normal anion gap acidosis. Now, why this is a complication of decay? Decay per se causes high anion gap acidosis because of the elevated ketones levels. But during the resolution phase of decay, if you have given too much of fluids, especially normal saline, they can actually go into a normal anion gap phase. So you can have a normal anion gap acidosis in these patients as well, especially with the use of normal saline. So now option number 4, you can say it is debatable. It's not that it's a completely correct thing, but you can have. And coagulopathy as such is obviously not related to DKA per se. Question number 4. With regards to glycemic control in the ICU, which of the following is true? Risk of mortality increases with variable sugars. Option 2. Tighter sugar control at lower range is associated with better outcome in uncontrolled sugar patients. Option 3. Nice sugar and Vicep trial showed that intensive insulin therapy associated with better outcome and reduction in the insulin infection risk. Option 4. Capillary blood sugar is the gold standard in shock patients. And option 5 is sitagliptin associated with worse cardiovascular outcomes. So after each section, I'll give a brief 5 to 6 minutes overview of that particular part, the general theory part, then I'll move on to the next section. So this one, if you look at it, the regards to, so the first option, risk of mortality increases with variable sugars actually is true. So there is something known as a coefficient of variance, which actually indicates that if that is increasing, so that indicates that is associated with higher mortality. So if a patient is having uncontrolled diabetes, you tend to keep the sugar in the ICU at a higher level, not strictly controlled to a very low levels, because this variation also associated with worse outcomes. Similarly, if the patient is having well-controlled diabetes or non-diabetes, their sugars mounting up to above 200 or to 300, that is also associated with bad outcomes. So option 1 is correct. Tighter sugar control has never been shown to be associated with a better outcome after the initial trial by Vanderberg et al. That was in surgical ICU patients. That was the only trial which showed that there was an intensive insulin therapy associated with better outcome. But after that, every trial is negative, and the recent trials are coming up with the data that is showing that there can be harm. So you don't go for tight sugar control, you go for a modest sugar control between 140 to 200. Even the recent paper on it, that is known as TGC paper, came in NEJM, and that has highlighted that even a slight or mild sugar control of around 215 is also acceptable. So now people are moving towards something known as permissive hyperglycemia, just like permissive hypercapnia. Nice sugar and Vicep are the trials which negated the use of intensive insulin therapy. And the trials before to that were the ones where Vanderberg et al. Trial showed that there was some benefit with intensive insulin therapy. So again, it is the reverse. Nice sugar and Vicep exactly showed the opposite. In shock patients, we cannot rely on the capillary sugar because it is obviously erroneous. You have to sample from the blood and measure the sugar. Sitagliptin associated with worse cardiovascular outcome is actually true. Although this is not particularly related to glycemic control, but many trials have shown that sitagliptin per se is associated with cardiovascular outcomes worsening. Question number 5, DKA and HHS. This is very straightforward. Which of the following is true? Option 1, DKA associated with mortality, higher mortality. HHS typically have very high sugars. HHS require more insulin therapy. Severe dehydration and therefore enormous amount of fluid administration is the hallmark of DKA. And pH has to be acidotic in DKA patients presenting with vomiting. Which of the following is true? Any answer? Any answer for question number 5? Which of the following is right? So I'll discuss the answer. So the first option is actually incorrect. HHS happens in more elderly patients and it is associated with severe dehydration and relatively less insulin deficiency. HHS is having more mortality. And HHS, as I said, it is associated with higher sugars. Typically, more than 800 is the cutoff. HHS requires less insulin therapy. So option 3 is incorrect. Severe dehydration, as I said, is a hallmark of HHS. And pH in a patient with vomiting, they can have mixed disorders. They can have respiratory metabolic alkalosis because of achloridria, and therefore they can have a mixed metabolic alkalosis, acidosis, respiratory acidosis, alkalosis. So they can have a normal pH as well. So don't rely only on the pH for diagnosing DKA patient. DKA. So this is and the last question from this topic is based on this. This I have made out of my mind. This is not particularly did not come in any exam per se. A 45-year-old diabetic patient was taking some oral hypoglycemic agent and subsequently she admitted to hospital with obtunded status. She's drowsy, skin turgor is low, she's in shock, blood pressure of 90 upon 50, and an ABG shows severe hyperlactatemia along with metabolic acidosis. Her ketones are, trace positive. and what's the next best step. So this is basically looking at a high iron gap acidosis along with high lactate levels, sugars not in the range of DKA per se, but something is wrong with the patient. And especially the lactates are very high given the fact that patient had history of loose stool and some OHA intake. And the options for treatment, what is the best option? IV insulin, IV fluids, electrolyte management, and anti-infective measures just like DK, IV insulin, IV plus IV insulin. Could you hear? Actually, I got cut off. I could not understand that. Yeah, probably it was some
Aspirin,
connection error.
aspirin,
Which
please
part?
continue.
Yeah. Till what part did you could you see? Anyone can tell me? So, did you go? Did you come? I mean, did you follow till the last part of the questions at least? Okay, I'll move on to the next. I'll continue. If there is any doubt, please let me know. So I was discussing that we no longer follow the intensive insulin therapy anymore because it is associated with more harm, and therefore, hypoglycemia is more sinister. Therefore, we don't follow that, and we kind of maintain the sugar within 140 to 200 range. And hypoglycemia per se, hypoglycemia could be because of various drugs, could be because of sepsis, could be because of alcohol intake, acute alcohol intake, could be because of some administration of insulin, exogenous insulin administration, could be because of insulinoma. Not going to the causes of hypoglycemia, but if you suspect hypoglycemia, you have to treat it with dextrose, 50% dextrose, 50 ml. That's a standard dose, 25 grams of dextrose. And if your hypoglycemia is not responding to your dextrose, means something more is there, probably a sepsis. So you escalate your antibiotics. Could be a steroid deficiency. So you have to give a hydrocortisone stress dose that is 200 mg over 24 hours. And in some cases, especially in sulfonylurea poisoning, many patients are on glimepiride or glyclazide. They can present with persistent hypoglycemia despite giving almost 50, 60 ml per hour of high dextrose. Then you have to start octreotide. Octreotide actually reduces the insulin secretion from your pancreas and therefore reduces the hypoglycemic spells. And if you have a prolonged severe hypoglycemia, you can have something known as this, where you see that the putaminal structures are lightened up. So you have diffusion restriction images, diffusion restriction positive in areas where you have higher cellular metabolism like hippocampus, cerebral cortex, basal ganglia, etc. And chronic prolonged can cause severe neuroglycopenia and severe irreversible damage. Coming to DKHHS, so DK, you have to have the presence of diabetes, that is more than 250 sugars, ketonuria or ketonemia and acidosis, all of the three should be present. It is generally higher iron gap. Towards the later end, it might have a normal iron gap acidosis. Okay, so people are asking that the hyperlactatemia part they have missed. Okay, I'll just quickly go through the DK part. I'll come back to that. So regarding the management of DK, we have to start off with an insulin which is a 1.5 units per kg per hour infusion or at 0.1 units per kg bolus, and then you run an infusion. What is important to take away points is that there is an entity known as euglycemic decay that is seen in starvation, where you have loss of sugars, so therefore you have lower normal blood sugar levels. You can have in pregnancy similarly, because in pregnancy there is the cutoff or the threshold for glycosuria actually comes down, so you have more glucose glycosuria. And SGLT2 inhibitors. So many patients who are on empagliflozin, dapagliflozin, they can come with euglycemic decay. You avoid intubation as much as possible in these patients, and you don't give any bicarbonate solution during the acute phase. It because you have to give balanced salt solution, that is a standard nowadays. And the difference between DKHHS, HHH is much more sinister, much more hyperosmolar, happens in elderly, more mortality, more fluid deficit. So ADK is lesser severe, HHH is more severe. And treatment, you people mostly are aware of it. I'm not going to the individual details. Complication, as I said, cerebral edema is one of the complication in young patients because of rapid correction, and the severity of decay is dependent on the pH, the glucose levels, and the serum osmolality can be variable. The most important is anion gap. So only the ketones per se does not indicate or the severity of the decay. So coming
Yes,
to
yes.
the uh, so the question one, this is the question where you missed out. Okay, I hope that the question was clear. A young patient who was on diabetic patient with OHS. We don't know the what OHS. Patient came with shock, hyperlactatemia, acidosis. I was mentioning that this could be a MALA. The entity is known as metformin associated lactic acidosis. Why it happens? Because metformin goes and inhibits the pyruvate decarboxylation in the mitochondria, and therefore it reduces the oxidative process, and therefore the pyruvate gets diverted towards making more amount of lactates. So therefore, metformin toxicity is one of the entities which is not so uncommon. The term is mala because we are never sure whether my metformin is the only source of the lactic acidosis. So it can be because of something else also. Only if you take too much amount of metformin, that is more than 20 grams, you develop metformin induced lactic acidosis. And as I said, the clinical features I've already discussed. Treatment, one thing to add except for the supportive therapy is that you can have extracorporeal removal of the metformin. So you can add a hematopsin filtered along with the dialysis circuit, and you can absorb it and preferably start as early as possible. What is the criteria for that? Just remember, if you have a very high lactates and acidosis, you can go for extracorporeal therapies. So now we'll move on to the next part of the endocrine part. So I'll move on to the questions first. And then we'll, as I said, I'll quickly brush through the important topics. So question one, okay. Which of the following is true about CERC? CERC stands for critical illness related corticosteroid insufficiency. So CERC, which of the following is true? In patients with sepsis and normal MAP, CERC can be a cause. Normal values of 9 to 24 in critically ill patients. Value more than 20 almost rules out CERC. ACTH stimulation should be done with the low dose, that is a 1 micrograms or micrograms of cosintropin, and change after ACTH of less than 9 predicts worse outcomes. Which of the following is true? Only one answer. I mean, only one option is correct. Anyone? This is the tell you that I'm not cut off this time. Any volunteers? I mean, this is very basically. I mean, this question can be asked because this is on a very important topic, that is CERC. The correct answer is actually answer 5. Okay. So in patients with sepsis and normal MAP, we don't go for steroid therapy. That is very normal values, difficult to mug up. It is 5 to 24. Am I audible? Hello? Am I audible? Okay. So basically, in patients with normal values actually is 5 to 24. So that is one thing to remember. Value more than 20 does not rule out CERC. Actually, I'll show you some data that CERC is a relative insufficiency of mounting an adequate steroid response with respect to a stressful episode. So your baseline might be very high, but if your increase in the steroid levels, increase in the cortisol after a stressful episode, that is, we test it by doing the cosintropin test. If that is a negative or that is insufficient, it indicates that you have a higher mortality. So value more than 20 does not rule out CERC. ACTH stimulation is done with a standard 250 micro cosintropin test. It is not with a low dose, and the change after 9, that's why it predicts a worse outcome. Correct answer is option 5. Question number 2. Which of the following is true about myxedema coma? Generally, all patients are obese, thick skin, hide leg, thick skin. They are having hirsutism and comatose. Option 2, combination of thiamine, dextrose, hydrocortisone, thyroxine is used in metabolic shock. Option 3, HAT therapy. HAT therapy stands for hydroxy, your vitamin C, and then you have ascorbic acid and thiamine. So hydrocortisone, ascorbic acid, and thiamine therapy has been shown to be providing mortality benefit. Treatment should be started in suspicion of if present, as it's associated with higher mortality. And T3, triiodothyronine, is more potent but toxic than T4. Which of the following is true? So there are two options which are actually true. Three options actually which are true. So any volunteers? So this is the question. Anyone volunteering? I think it's best that I cannot go to the chat box and find out the answers. So if someone can prompt their answer, or some moderator can prompt the answers from the chat box, that would be beneficial, because I cannot see the screen over there. It's a full screen thing. So anyone to volunteer? Because if I have to go to this screen to look at the options, then basically I'm losing track of this screen only. Okay, somebody answered 3 and 4. 4 is correct. It is obviously right option. And 5 is correct. Actually, multiple choice questions. This is actually 3 options are correct. 2, 4, and 5 is correct. Right, rest 2 are incorrect. So myxedema coma is actually a misnomer. You don't always guess thick skin, obese female patients. That's what we are thought to believe. But any hypothyroid female patients, mostly they're females, coming with shock, you should always suspect myxedema coma. Now think it like that. If a patient is on thyroxine for a long time and somehow misses their thyroxine dosage, and next 2-3 days down the line they'll end up in coma, would they swell up like anything? They will not get the time to swell up. So myxedema does not occur in most of these patients. And the patients who are chronically hypothyroid for a long durations with the TSH levels of more than 200, they will have all this edema, all this thick skin, pericardial effusion, pleural effusion, all these things. But because they're kind of acclimatized to the situation, they will never go into coma per se. They can go, but it's rare. So coma also, it's not an exactly coma. The patients can have only hypotension and hyperlactatemia, hypoglycemia. So both of these terms are actually incorrect. So it should be termed as severe hypothyroid syndrome, severe hypothyroid state. So the option 1 is incorrect. In metabolic shock, if you see that in some patients your lactate levels are rising, even in sepsis patients as well, there was sometime HAT therapy, that is hydrocortisone, ascorbic acid, and thiamine was usually given, but as such, there is no scientific evidence. But if you suspect a metabolic shock, especially like in a case like this, in a patient we suspect that could be myxedema, you can give it. Next is treatment should be started if suspicion if the patient is high. Obviously, patients are very high mortality. The treatment should be immediate. You should not wait for the lab values. If you suspect, just immediately go for an IV thyroxine. And T3 is more potent but more toxic. Patients T3 responds faster, but the dosages and the therapeutic drug range, dosage range is very narrow. Therefore, you can have very high rates of atrial fibrillations. Moving on to the next question. Okay, which of the following is true about thyroid storm? Thyroid storm. So diagnosis always is based on lab values. Number 2, steroid is used for treatment. Option 3, beta blocker can be used as a solo therapy. Option 4, PTU, that is propyl thiouracil, it's one of the antithyroid drugs, should be given after Lugol's iodine solution. And Plex, that is plasmapheresis, can be used. Any volunteers, kindly speak up, because as I said, I cannot go back and look at the options there. Then lose the track of this skin.
Solo.
So there are multiple choice options. Actually, this is also multiple choice. Multiple choice with multiple correct options. Any volunteers? Anyone can speak up. I'm not looking forwards to only correct answer or anything. I just anyone to participate. So the first option, that is diagnosis always based on lab values, is false, because thyroid storm is a clinical diagnosis. Any patient presenting with a hyperthyroid state on the background and presenting with toxic symptoms. That's so it's based on the toxic sign symptoms we diagnose thyroid storm. It is never based on lab values. The patient can have a TSH of less than 0.005 but still not have thyroid storm, and patient can have a TSH of say 0.05 and have a thyroid storm because your T3 T4 levels could be very high. So it's not based on a diagnosis of lab values. Next is steroid is used for the treatment. Yes, hydrocortisone is used because it inhibits the conversion of T4 to T3. That is one of the modes of its action. Beta blocker solo therapy is can be dangerous because these patients have high output cardiac failure. So their cardiac output can be based on only the heart rate. So if you give beta blocker to reduce the symptoms, they can actually go into an acute left ventricular failure. I don't mean to say that you don't give beta blockers. It can be given, it should be given, but it should be given in a guarded way along with other therapies like antithyroid drugs, steroids, and leukocytin solution. Propyltyrosine and the leukocytin, the thing we have to remember is iodine can inhibit the hormone release that is based on the Wolff-Chaikoff effect, where it constipates the thyroid, or it can help in the release of further thyroid hormones based on Jod-Pesto phenomena. So if you give iodine, you don't know which way this is going to go. So if you want to give iodine, you have to give it after you have administered an antithyroid drug. So you give it after the PTU. So Lugol's iodine should be given after PTU, not the reverse way. And plasmapheresis is a very good option for a significantly sinister thyroid storms. And there are other options like cholestyramine, which can be used, and that basically reduces the enterohepatic circulation of the thyroxine. If you have taken excessive tablets, or if you have a thyroxine normally also, so that actually has an enterohepatic circulation going on that increases the GI absorption. You can go for cholestyramine therapy as well. Now, question number 4: which of the following is true about steroid use in pneumonia as per the latest literature? So steroid is indicated in severe pneumonia without shock. Methylprednisolone is preferred over other agents. A dose of 400 to 500, that's very high dose of hydrocortisone equivalent is required. Higher dose steroids lead to better outcome. And fifth is cannot be used in immunocompromised patients. Which of the following is true? So which options are true? Any volunteer, please, Fatma, if you're there, can you please prompt up the answers, because I'm not able to go to the screen because no one is prompting. So I will go ahead with the answers because I cannot go and check individual answers. So as per the latest literature, as per your level, it is enough to know that severe pneumonia, you can give steroids. Rather, you should give hydrocortisone, and to reduce the chance of ventilation free days. I mean, to reduce the chance of ventilation days and improve the outcomes, irrespective of your. Only thing to remember is that you have to rule out influenza and bacterial pneumonia. Definitely, you can go for hydrocortisone. If you are unsure about use it, you just send a CRP levels. If the CRP is very high, you can go ahead with steroids. Methylprednisolone is not preferred. Hydrocortisone, as per the literature, is preferred. Per se, there is no difference between the type of steroid usage and the outcome. So you can use anything. If you are using hydrocort, that is based on the literature, you can use it. If you are using Predmet, you can use it. Dose is 200 mg hydrocort equivalent per day. Higher dose does not lead to worse or better outcomes. That's obvious because it leads to more infection and all, and it can be used in immunocompromised patient. It is not a contraindications. For example, if you have a PCP pneumonia, pneumocystis carinii or pneumocystis cerovis pneumonia with severe hypoxia, elevated alveolar arterial gradient, amount of steroid. Option 5. Question 5. Which of the following is true about steroid use in septic shock? Previous was one steroid use in pneumonia. Now this is steroid use in septic shock. Now this you people might have to know a bit of the few trials, not everything, but these are the few trials you must be knowing, because in questions can be asked of these trials. Steroid use in septic shock. So the landmark trials, what are their results and how they modified our current practice? Adrenal trials showed mortality benefit. Approx trial showed harm with the use of steroids. Should be started only if an noradrenaline dose exceeds a certain limit of 15 mics per hour. That's a 0.25 mics per kg per minute. As per the literature, fludrocortisone should always be used with hydrocortisone, and hydrocortisone infusion is preferred over boluses. Which of the following is true? Again, there are multiple choice options which are true. Rather, actually, this is actually single option which is true. not multiple. Single option is true. So people are saying 2. Actually, no, 2 is not the correct option. Actually, adrenal and approx, the results actually have written in a reverse manner. Adrenal was a negative trial, approx was a positive trial. So this negates the first and 2 options. Both are incorrect. Should be started if NORAD requirement goes above certain range of 0.25. That was as per the previous sepsis guidelines. Now the sepsis guideline tells us that if you are having a patient who is persistently requiring vasopressors, previously they used to say that you have given enough of fluids and despite the fluid patient is requiring vasopressors, you have given NORAD despite the fact you are requiring vasopressor escalation, you should consider. Now they are saying that during the resuscitation phase, if there is a persistent use of vasopressor, you should consider steroids. That is a stress dose, 200 mg bolus followed by 200 mg over 24 hours. As per the literature, fludrocort should be always used along with hydrocort. This is a controversial, but surprisingly, this is actually true. Although physiologically, this cannot be supported, but if you go back and read the literature, every trial which has a positive outcome with the use of steroids, especially with terms of mortality benefit, they have used hydrocortisone along with fludrocortisone at the dose of 50 to 100 microgram per day dosage. And every trial of them found out to a positive trial. However, nobody can tell what is actually the reason. It could be that the trial designs were such that early use of steroids were advocated in few, leading to mortality benefit and all. But it is as per the literature, fludrocortisone is beneficial. If you ask me physiological wise, there is no other rationale because hydrocort has an equal mineralocorticoid action of 1:1 or more. So it is equally as good. You don't need a fludrocort for that. And infusion is preferred over boluses. This is an incorrect statement. You can use either of them. There is no benefit of one. Pretty well give a bolus dose that is 50 mg QID. You don't need a infusion. Okay, so this is the questions on this topic. Now I'll briefly go through the section on the hair in next 5 to 6 minutes. This is a lengthy one because it's adrenal and lot of thyroid, so there is a lot of discussion. I'll quickly go through the important things. So if you consider the adrenocortical functions, so there are different adrenocortical deficiency could be there, or excessive hormone production could lead to different syndromes and their signs. Cohen syndrome and Cushing syndrome are hyperproduction of mineralocorticoids and glucocorticoids respectively, whereas Addison's and hypoaldosteronism, these are all signs of reduction in the hormone synthesis. So the clinical features, it's that if you have a Cohen's, you have hypertension along with hypokalemia is the main presenting feature. If you have Cushing's, you have uncontrolled diabetes, hypertension, fragile bones, weight gain, moon phases, everything is the main clinical features. Addison's has its typical, we'll come to that. So adrenal insufficiency is a term which is used in critical care. The causes of adrenal insufficiency could be various. Could be that the binding proteins are reduced. Could be that the affinity for the hormone towards the receptors and the sites are reduced. Could be a relative resistance to its action towards the receptor. So various mechanisms are there. So steroids generally have an anti-inflammatory effect and has a eosinopenic effect, has a neutrophilic effect. And the causes of AI, that is adrenal insufficiency, could be primary, that is adrenal gland disorder, like if you have an adrenal gland hematoma out of Waterhouse-Friderichsen syndrome, or because of DIC you develop an adrenal gland hematoma, you have an adrenal gland infiltration. All these things lead to severe adrenal deficiency. So you have to know that, so hemorrhage infections like tuberculosis, histoplasmosis, cytomegalovirus infections, this can cause secondary AI, that is adrenal insufficiency, secondary to secondary AI that would be indicating a pituitary cause, and pituitary would indicate an infection of the pituitary or a trauma to the pituitary gland or an infiltration like sarcoid, and sometimes your amyloidosis also can affect it, and postpartum pituitary necrosis, that is known as a Sheehan syndrome. Some drugs obviously reduce the production of steroids, so it's iatrogenic causes like ketoconazole, metidapone, and mitotens, they can cause an artificial adrenal insufficiency used in a long set. This is a basic steroidogenesis. I'm not going to this one. Clinical features include fatigue, hypotension, hypoglycemia, dark colored skin, hyponatremia, hyperkalemia, metabolic acidosis. Generally, these are normal and metabolic acidosis, hyponatremia and hyperkalemia. Especially hyponatremia is universally seen, hyperkalemia plus minus. Adrenal crisis precipitated by an acute stressful event. So you can have a hemorrhage, surgery, infection that has precipitated the adrenal insufficiency. And one question was asked, or one option was there, ACTH stimulation test. What is the correct dose? The correct way to do it is giving a cosintropin 250 micrograms at 11 p.m. in the night. That is either IV or IM, and you draw cortisol samples in the morning. If your ACTH response is good, means your HPA axis is working fine, then the cosintropin should give rise to an adequate increase in the is cortisol levels. That is at least 9 milligrams per deciliter increase in the baseline. If you have an increase in the baseline that is less than 9, that is associated with worse outcomes. That was actually shown in the NN trial. And low dose has no effect in critical care, so it is not of use. Management, obviously giving steroids, and you'd have to follow this chart, that is the equivalence of steroids based on your different steroids. So hydrocot 20 is equal to methylprednisolone 4, prednisolone 5, dexamethasone, betamethasone 0.75. This is how you remember. You have to remember this chart your lifelong for use in critical care. And as I said, the diagnostic algorithm based on the cosintropin stimulation test, if your cortisol is less, now you look at the ACTH and the cortisol. If your ACTH is high, it means that your adrenal is actually working abnormally. And if your ACTH is low, it's a pituitary which is at fault. Then you have to go on further elaborating the diagnostic points. You can go ahead with adrenal antibodies testing. You can scan the adrenals with an ultrasound or a CT scan, look at whether there is an hemorrhage or an infection. Where you can go for a biopsy if there is an adrenal tumor. You can find histoplasma tuberculosis in that. And if you have a because you straightforward go for an along with MRI brain, and that will tell you what is the structure of the pituitary, whether there is an infiltration or not. Adrenal insufficiency in perioperative period, just remember that if you have a patient who is coming on background of steroids for at least 5 mg for 4 weeks in the previous 6 months, you have to give steroids at the beginning of the surgery as a stress dose and give it in the replacement dose in the next 24 hours. And CERC is a relative adrenal insufficiency. And the point I was about to focus is, look at this. There was one trial which showed that the ones who have a baseline cortisol level which is higher than 34, that is not above the normal, but the increase to a cosintropin less than 9, as per the NN trial, actually had the worst. So, which means that your steroid levels are higher than baseline to start with, actually means you are more stressed than before. And if you mount an adequate response over and above that, then probably you have a lesser mortality. You are mounting an adequate response, but if you are unable to actually experiencing more mortality. And rather, patients who had a less cortisol level at the baseline, less than 34, means they're mounting the response nicely, actually has the best survival. So a B from a no CERC, and the cosintropin stimulation with the 250 is the standard of care choice for diagnosing it. As per the latest things to take care of in ICU, and a cosintropin test in an ICU setup does not have the scientific merit like a guideline. Particular dose of steroid is particular dose of the response. Some sound is bad. I guess it has to do with the any issue with the sound right now. Go to the next part. That is, CERC diagnosis is similar like clinical features are similar like Addison's. Not going to the details. And the trials that I was going to mention, that these are the landmark trials. The Corticus trial, which was a negative trial based on the use of steroids. The Approx trial was the one which first showed that there was benefit with use of steroids, especially in the early mortality reduction, and there was early attainment of vasopressor reduction. So even if you are using steroids, just keep in mind that it is not going to make a huge difference in the outcome. but it is going to reduce the chance to discontinue a vasopressor. So early treatment of an earlier discontinuation of the vasopressor medications. That is what we're going to achieve. High press trial was again a negative trial. Adrenal trial was a negative trial in majority of part, but it is actually adrenal trial with major drawbacks. If you go and read the individual trials, you will have 3-4 points in each of this trial, which you can remember. But these are all landmark trials with the use of steroids. And next, coming to the recommendations, I've already said. Steroid other uses. It is used in ARDS patients. Early use of steroids, especially in organizing pneumonia patterns and DAD, diffuse alveolar damage patterns, is recommended. It can be used in patients with negative cough leak test after you have suspected that patient can have post-extubation stridor, in patients with PJP pneumonia with severe hypoxia, patients with early onset community acquired bacterial meningitis due to streptococcus. It can be used to reduce post afterbirth neurological outcome, especially reduces the cranial nerve palsy. And in if you are using because it inhibits the steroidogenic hormone. Cushing's is a syndrome that is associated with excessive glucocorticoid generation. Disease is when you have a problem with the pituitary. So when your pituitary having a macroadenoma and that is causing an ACTH stimulation, ACTH excessive secretion, that is called Cushing's disease. And when you have the adrenal gland secreting a tumor that is not because of exogenous drug administration, that is exogenous steroid administration, or ectopic ACTH secretion from lung cancers, including Cushing's, is that first you do a 24-hour urinary cortisol assay. That's based on the ward patients actually. But the most useful test in an ICU or a critical care would be a dexamethasone suppression test. You give a very low dose 1 mg in the night and then draw samples in the morning. And if the reduction if the after the dexamethasone, it actually should be less. So the cortisol should come down below a certain point. But if cortisol stays above 50 millimoles per liter, that is more than 1.8, it indicates that the patient is having Cushing. And for confirmation of Cushing's, you have to go for a higher dose dexamethasone suppression test. That is, 8 dosages are given in the 48 hours. Now, there is one twist. So, something known as a continuous low dose dexamethasone suppression test versus dexamethasone, the adrenal gland or the pituitary gland. You do the first test, that is the continuous low dose dexamethasone suppression test over 2 days. You give 2 dosages each day at 11 p.m. and look at the average increase in the serum cortisol levels, and that if your cortisol is still elevated after the high dose dexamethasone, it is the gland which is the problem. If your cortisol reduces, it is the pituitary which is the problem. And a high dose dexamethasone suppression test. And if your pituitary is hyper functioning, then it will not get subdued. It gets somewhat subdued by the high dose dexamethasone. There will be a 50% reduction in the cortisol levels after giving high dose dexamethasone. Whereas the ectopic acid from cancer won't respond to it nicely and keep on getting elevated. So that's the thing about the Cushing syndrome. And drug therapy, use all the azoles which inhibit the steroidogenesis. You can use metidapine enzyme in the steroidogenesis. You can use etomidate in the ICU for a low dose infusion, but it's rarely used. And you can use something known as pasireotide and cabergoline to reduce the pituitary hormone secretions. Excess. So that's a tumor gland high. Usually seen in young patients coming with young hypertensives. You should suspect if you have a patient with plasma, renin, and your aldosterone ratio. So this is very important to know. What nutrition and plasma renin activity are two which you send. Normally, hyper affected by the aldosterone. So if your plasma aldosterone is higher, means regarding the diagnosis, as I said, that you should go for something known as a salt loading test. That is, you give a saline loading bolus or excessive oral salt and see that if the patient has an aldosterone reduction after giving it. If not, then it is positive for Conn syndrome. You can go for captopril challenge test 25 to 50 mg to see the ARR. That is the aldosterone renin ratio again. And you can simply go for a radionuclide scan, the Rotanox scan, and abdominal scans to diagnose if there is an adrenal tumor which is causing the Conn syndrome. Management is mainly again mineralocorticoid receptor antibody drugs, analogs like you give pyrrolactone, eplerenone. These are the drug of choice. Now coming to the basics of thyroid. So thyroid is a hormone, different proteins. The main activating factor in thyroid. Sound is bad. People are. Is my slide moving now? Just give me 1 second. I'll just look at my network connection. Is my screen visible and somewhat audible? Okay. No slide. Okay, I'll just then share again. Is my the screen visible now? Hello, am I audible?
Yes, sir.
Yes. Is my screen visible? Screen visible, right? Okay. So I'll resume. Fatma, please let me know if there is a glitch, technical glitch. Just let me know. Okay. Okay.
Sure, sir.
Okay, so thyroid physiology, as I was saying, the thyroxine is the T4 and T3 are the two hormones which are main important. T3 is the active metabolite, which is more bioactive, and it has got more affinity towards the receptors, less half-life, but more toxic. T4 is the one which is progenitor. So T4 gets converted to T3 in all the active sites by the deiodinase enzyme, and different deiodinase enzymes that is different function. And what happens in critical care is something known as a sick euthyroid syndrome. The new name for sick euthyroid is non-thyroidal illness syndrome, NITS. What happens is that the 5' deiodinase, which is supposed to convert a T4 to an active T3, gets kind of mutated or abnormal. And because of that, the reverse T3 increases. And the reverse T3 is not so active as T3. And therefore, the functionality of the T3 reduces. And therefore, you have a kind of a functional kind of an abnormal sick euthyroid state. And the what is near normal, but the T3 is low, and TSH is normal or slightly on the lower side. It is never elevated like a typical hypothyroid patients. And do you need to treat these patients? No, it has not been shown that giving thyroxine to a sick euthyroid patient and improves outcome. So it just have to just keep a close watch. That's it. Something important to know that in critical care, and commonly used drug that is amiodarone can cause an amiodarone-induced cytotoxicosis. There are two types, 1 and 2. The first one is actually an acute thyrotoxicosis kind of picture, where amiodarone goes and binds to the thyroid gland and increases the release of thyroxine, causing a thyroid storm kind of picture. And the next one, AIT2, it's much more of a Hashimoto's type picture where you have reduction in the thyroid hormone synthesis. So, thyroid storm, as one MCQ was directed, thyroid storm is a clinical diagnosis. It is not a lab diagnosis. If you have a patient who is having some sign symptoms of hyperthyroidism, like these eye symptoms, like von Grapp's sign, PS sign, Joffroy sign, Dalrymple sign, etc. You have pre-tibial myxedema and all. Along with that, if you have toxic features like tachycardia, high output cardiac failure, diarrhea, sweaty palms, palmar erythema, etc. These are symptoms of toxicity. And but this is known as Birch and Wachowski is there or not. So it is based. Sorry for the interruption. I'll just share the screen again. There's a lot of glitch today. Is my screen visible now? Is my screen visible? Slides visible? Hello? Is slide working? Someone please volunteer. Otherwise, I'm not able to go forward. Is everyone able to see the slide? Okay, no slide. I'll take it again. Okay, I'll just share again. Stop share. New screen. Okay, now is the slide seen? Is my screen visible? Okay. Voice. Voice. I guess that there is someone who is hearing nicely. Someone who is not able to hear. I can apologize at the best right now because I can't change my right. I'm in the hospital and I can't change my network connection at ease. So bear with me for some more minutes and do ask me if there is any question at the end. Okay, as I was saying, the thyroid storm, so you cannot give beta blockers blanketly. You have to be careful that it can cause severe cardiac dysfunction in thyroid storm is quite common, and therefore you can reduce the chronotropicity and that can cause severe shock. So beta blockers are somewhat to be given with carefully. Methimazole is an antithyroid drug which can be given. The dose is 20 to 40 mg BD. Leukocytin solution should be given after you have administered an antithyroid drugs, and that is what was asked in one of the MCQs. Cholestyramine reduces the enterohepatic circulation of the thyroxine hormone, and therefore it is reduces the thyroxine reuptake and reduces the thyroid storm management. It can be used, and in extreme cases you can go for plasmapheresis as well. Myxedema coma, it's a misnomer. Neither the patients are edematous, neither the patients are actually that sick or that obese. So patients generally are elderly females who come with the missed dosages of thyroxine over few in shock, hypoglycemia, cold thready pulse, and they are having hypothermia. So these are the clinical features. That's what defines myxedema coma. And if there is a one single lab value we can monitor, you have to send a TSH. Generally, TSH comes above 100 to 200 at least. You don't have a myxedema coma at 20 TSH. You can never have. So secondly, is that you don't always rely on the lab. You don't wait for the labs to come back. If you suspect myxedema coma, just give a dose of thyroxine via the RISE tube at least. If you have an IV thyroxine preparation, which we don't have, most of the hospitals don't have, you can go for a dosages of 200 to 400 micrograms IV. So if you are treating a myxedema coma, start with a very high dose of 5 to 10 tablets of thyroxine at least, and then you keep on to around 100 microgram per day of replacement doses. That is okay. So these are the questions. So this part, endocrine part, is done. Now, before I move on to the next PPT, any question? Since a few people have said that they are not able to comprehend few things and all. Anyone that any part that any particular thing you want to get repeated? Okay, so I'll move on to the next part then. Before moving on to the next part, is my screen visible? Is my screen visible? Anyone to volunteer? Is this screen visible? Okay, good to hear that. I don't know how much long it will, stick like that. The correction is kind of weak. So I'll quickly brush through a few questions. Be attentive. So this is on the organ donation part. Okay, this is a huge thing. So I'll just briefly in next 15-20 minutes, I'll try to wrap up this. So for first question regarding organ donation in UK, once a decision, it is UK, although it is also applicable in India per se, as per this question. Once a decision of organ donation is made and you have diagnosed brainstem dead, the approach shifts from a patient oriented to an organ procurement approach. So it's a true false answer, true and false. You have to answer like TFTT or TFTT, TFFFTT, like that. Regarding the donation of after cardiac death, DCD, it is acceptable to delay the process of withdrawal till you have a process of the procurement of organ in place. Verbal consent of the donor is enough to validate the organ retrieval process posthumous. Family consent is mandatory even if the donor is consented prior and must be more than 18 years of age to categorize as a donor. So the correct options would be that option 1 is actually true. That is, you have to shift from a patient oriented to an organ procurement approach. So everything you do after a brainstem death is basically saving the organs. Regarding the donation after DCD, it is acceptable. So option 2 is also true. Verbal consent is also true. You can actually go ahead with a donation if you have a verbal consent prior to death from the patients. But family consent is not mandatory. If the patient has consented, that is enough to negate the family's wish. So if the patient has said the donation has to be done, it has to be done. And generally more than 18 years of age is the guide. As per the guideline, is still most of the papers say 18 years is the mandatory, but as low as 16 years can also be donors. So it's a dicey option. Option 5, I'll leave it to you guys. It is correct in many countries. It's incorrect in many countries. Depends on which country we're basically giving the exam from. Now, this is one important thing. Functional ischemia time. Mark the true and false. Which of the following is true and false? Functional ischemia time begins from asystole. So this is cold ischemia time from is the time from harvesting the organ till you are putting back to the patient's actual preservative solution. Diabetic and hypertensive patient cannot donate kidney. DCD, that is donation after cardiac death, is not suitable for heart donation, and NORAD is the first choice in fluid unresponsive patients with post brain dead donation, organ donation. So I will just go through the topic. So functional ischemia time is begins from asystole is the wrong thing. So ischemia time actually is the low perfusion status. So if you have a severe hypotension preceding your cardiac arrest, that also adds on to the ischemia time. So it is the starting is from the low perfusion status. That is the time. Cold ischemia time is that supposedly patient going into shock. So from that point till you have taken the organ and put in the cold preservative solution, that is the warm ischemia time. Again, after taking off from the cold preservative solution till you have connected to the patient, anastomosis is made. That is again a warm ischemia time. So the series is warm ischemia, cold ischemia, warm ischemia again. So total period of less perfusion, no perfusion is what is causing damage to the donated organ. Warm ischemia time is more harmful because it causes more ATP depletion and generation of lactate. So warm ischemia time is more harmful. Cold ischemia time harmful but less harmful because you're keeping it in a preservative solution. So it's maintaining the pH and the milieu to some extent. So cold ischemia time is somewhat better. Diabetic hypertensives are no longer contraindication for organ donation, especially kidneys. The control patients can give it. Although in India, diabetic patients are generally not candidates because they have this diabetic sclerosis, glomerulosclerosis, and all those things. So they're not candidates, but many places it can be given. DCD patients, cardiac arrest, obviously they cannot donate cardiac per heart. So that's the basic thing. And as per the organ procurement guidelines and all, patient is fluid unresponsive, you go for vasopressin early. NORAD is the first choice, obviously, but for a fluid unresponsive shock, you should go for vasopressin because your adrenergic or epinephrine receptors they actually get downtrodden and they are not so responsive. So you have to go for vasopressin, which acts by the different kind of receptors. I'll skip this question. This was not so important, but this one is important. A 24-year-old coming with road traffic accident and then severe TBI, your entire brain is white out, multiple bleeds and edemators and non-salvageable type. Blood pressure is 90 upon 30, which is very low. 2 liters of fluid you have given, still the blood pressure is low. Urine is 250 ml per hour. Hemoglobin 8, INR is slightly deranged because of trauma-associated coagulopathy, meaning that patient is basically non-salvageable. You have established brain death criteria almost. You have discussed with the family. Which of the following after this is true? So peripheral epinephrine boluses and more fluids are required for this patient. Secure central venous pressure, start vasopressin infusion. Thyroxine and steroid replacement are immediately required. Desmopressin replacement and target 50 to 80% of urine output and 5% albumin administration. Which of the following is true? And which of the following is the best immediate management? Any volunteers for this? Any volunteers? Which of the following is basically true? 1, 2, 3, 4, 5. One option is true among this. So it's pretty simple actually. So the actual option is actually 2. So since this patient is having hypotension after a suspected severe traumatic brain injury and you are sure that patient is not going to survive, you should put a just like I said, fluid unresponsive shock post cardiac arrest and or brain death if you want to procure organs. In those cases, there is a severe vasoplegic state. In that case, vasopressin should be started early as per few guidelines. And vasopressin you cannot give through peripheral cannula. You can give NORAD through peripheral line, but you cannot give vasopressin through peripheral line. Therefore, you have to put a central line. So correct option is option 2. Thyroxine steroids routine replacement does not help. Desmopressin replacement does not suit this situation because this is not shock because of hypovolemia because you have given 2 liters of fluid. 5% albumin as such, post-trauma, TBI, plus this situation does not warrant 5% albumin. Which of the following cannot be considered as a donor? Very basic opening question to a chapter. So, controlled hypertensive or diabetic patient for kidney. So, the question is which of the following cannot be a donor? So, what is the contraindication? Which of the following is a contraindication? Hepatitis B patient on tenofovir therapy, hypertensive diabetic patient for kidney transplant, basal cell carcinoma of particular area of skin which has not gone any therapy, disseminated tuberculosis with adrenal involvement, and primary brain tumor. Any volunteers for that? Which of the following is correct option? So correct option among them is option 4, disseminated tuberculosis. Because you control hypertensive diabetes can donate kidney. Hepatitis B, C, you have to consult a gastroenterologist and infectious disease specialist and discuss with the family. A controlled hepatitis B or C can give their liver and kidney graft. So it is no longer a contraindication. Basal cell CA is a locally aggressive tumor, nothing to do with the organs. So you can pretty well give it. And primary brain tumor is not a contraindication except for the fact if it is disseminated. So primary only located to brain, you can give it. Which of the following does not interfere with brainstem function testing? Very, very important and conceptual question. Which of the following does not interfere? So meaning to say, which of the following actually, I mean, you can go ahead with a brain dead declaration or something known as an apnea test, which I might be familiar with in these categories. Again, I'm rephrasing the question. In which of these following you can go ahead with an apnea test and mark them as brain dead? Pontine ischemic stroke with Loctine syndrome, suspected neurological poisoning like a snake bite or a neuroparalytic agent poisoning, severe head injury, GCS of less than 8, potassium of 3.1, sodium 160 and GCS of 3 out of 15, and atracheum infusion which has been stopped just 2 hours prior to your examination time. I would want some volunteers in this question. So this is actually quite an important question, to be very frank. Any volunteers for this question? I'm not getting the options actually. I mean, whether it's respect to the previous questions or the now on, I'm not able to make out. Anyways, so okay, somebody said 5, no. So again, I'm rephrasing. Which of the following does not interfere? Means which of the following you can go ahead with an apnea test and declare brain dead. So correct option is 3. All of them are actually confounding factors, including severe hypokalemia. But the hypokalemia here mentioned is 3.1. So the cutoff is below 3. So pontine ischemic severe. Now we will go to the discussion of brainstem death, and there I'll see that I'll quickly go through the part. So here the correct option is 3. All of them are confounding factors. So you cannot go ahead with the apnea testing. Now coming to the apnea test, one MCQ on that. Which of the following is true or false? If whole 10 minutes of apnea test is not complete, apnea test is indeterminate. If baseline PCO2 is more than 50, you cannot go for the apnea test. Oxygen passively is run at 6 to 10 liters per minute by any modes like a cannula during the apnea test. It can be done solely by the ICU team itself, and a single test positive indicate brainstem death. Which of the following is true? So let me tell you which of the following is true. Just identify the correct option. Only one option is true. Yes, option 3 is correct. Oxygen passively delivered, that is the only correct option. I'll discuss apnea test briefly after this. Now there are another question, 50-year-old. So apnea, this is regarding the apnea test only. 50-year-old male post-acute liver failure patient is having low GCS, cerebral edema is there. You go ahead and do this testing during apnea test. And during apnea test, the patient has a triple flexion. You see that the patient has a somewhat, feet, legs and arms, they are kind of folding, they're flexing. And the nurse, is confused. You are also confused. What should you do next? But there is no cranial nerve reflexes. There is the sensorium is obviously abnormal. It's still 3 out of 15. And other than that, there is no arrhythmias, no hypotension. You should stop the apnea test and declare the patient non-brain dead. You should scold the nurse and throw out outside of the ICU, like in many places consultants do that. You should call the neurologist and take his opinion, or you should proceed with the apnea test as before and go direct. Or option 5 is go for directly for a CT. Any volunteers for this? So this is actually something known as a false positive spinal reflexes. Spinal reflexes are purely spinal mediated. You don't need the brain for that. Many times we see that I should not be giving this referral or example, but many times when after the slaughtering of an animal, you see that their entire body is still moving around, although they are dead, right? So that's spinal reflexes. So like that, your spinal reflexes can be present even if you're a brain dead. So that spinal, there are various types. I'll show you a few examples, but this is one of the spinal reflex. So you can go ahead with the apnea test as before. Don't get panicked, and this is not a sign of brainstem functionality. Look at the CT picture. A patient has come after a history of fall from height, and then you see that this is a CT. And now a junior asks, sir, what to do? Do you go ahead with continuous aggressive mass resuscitation and call the neurosurgeon for an emergency decompressive craniectomy? Or you should start with hypertone coma and put an EVD and go for anti-epileptic measures or you should involve the organ donation bodies after due consent from the patient relatives, or just conservatively manage like whatever you're doing, whatever is good. What is the correct option? Anyone knows what is this sign called? This is a trivia question, not per se related to your this thing. So yes, actually it is a good option. Someone told option 3. This is known as white cerebellar sign. Look at this CT. You cannot see any base cisterns, nothing. The lateral ventricles, your cisterns, your posterior, the third ventricle, nothing is seen. Entire brain is swollen up, so much so that your cerebellum is now getting hyper dense. So that is hyperdense cerebellar sign, white cerebellar sign. This is suggestive of severe irreversible damage to the brain because of raised ICP, and most likely this patient has also has herniation. So you should go for organ retrieval at the most. And I'll come to your this thing will again discuss. One question was already asked on the confabulation of brainstem declaration. This is one of the trivia question again. We, as per the recent papers, which of the following is discredited as a routine measure after brainstem, brain dead declaration for procurement of organ? Desmopressin for suspected DI, that is diabetes insipidus. Steroids for vasopressor refractory shock. Vasopressin for fluid unresponsive shock, or thyroxine for suspected euthyroid state. So correct option is option 4. Thyroxine is no longer having that much benefit as it was thought to be. So thyroxine as a routine replacement therapy during brain dead donation management is now negated. Coming to now this one. This one is a conceptual question. I'll have a brief discussion on this as well. So 27-year-old male patient had a history of liver transplant, comes after 2 months, underscore 2 months of transplant. He has come to you with a frank episodes of, community acquired pneumonia. He is on anti-immunosuppressants, tacrolimus and mycophenolate mofetil. Patient is now toxic, and now you have to suspect some organism is there. You have to start some therapy. Which of the following is the most probable organism? Spikes. Spike stands for, there are some organisms which go by spikes. All the resistant organisms like P stands for Pseudomonas. Then you have the K stands for Klebsiella, Enterobacterial, Staphylococcus, Streptococcus, like that. So all these resistant organisms are spikes organisms. Okay. So would you go for the spikes organism cover with Aspergillus, Candida cover, MDR gram-negative cover? Would you go for the coverage of the PCP, CMV, Listeria, the opportunistic organism cover, or only the CAP cover, that is the community acquired pneumonia cover with a with a beta-lactam or beta-lactam plus erythromycin group of antibiotics, that is macrolide group of antibiotics, or did you think about some other causes or a PJP pneumonia on cotrimoxazole prophylaxis? Which of the following is true? 10 seconds, and then I'll move on to the, someone asked the answer 3. So the correct answer is actually 2. So the correct answer is 2. I will go to the discussion that it's based on the underscoring part is 2 months. So the difference is it's 1 and 6. Less than a month, it is hospital acquired infections, drug resistant organisms. More than 6 months, just behave like normal patients with CAP. So 1 to 6 months, any patients coming, it's mostly opportunistic infections. And solid organ transplant patient or opportunistic infection, you have to think about PCP, CMV, and in case of kidney transplant, the BJ virus infection, like that. So these are the main important things that you have to consider. Match the following drugs with toxicity. This I'll go in a bit later. I'll just briefly go through. And this is the question of liver transplant. Post liver transplant, liver failure. Patient has a liver transplant done, and on day 3, you find that this is the scenario. Your SGOT is 1000, SGPT is 1200, which obviously elevated. Iron is elevated. Hyponatremia is there. We want to evaluate which of the following is true or false. This I'll just have a quick discussion. So biliary complications like leak are common within first 3 days is incorrect. Most of the biliary complications occur after 7 days. Persistent coagulopathy and hypocalcemia after 12 hours of patient transplant indicate bad prognosis. Absolutely correct. Hyponatremia and hyperphosphatemia indicate good prognosis. It's the reverse. Hypernatremia, normal serum sodium levels and less than normal, or hypophosphatemia is actually good sign, because whenever the liver cells grow, they will take up the phosphate from the serum. So it's a good sign. Primary non-function of the liver is a benign entity and it can be treated conservatively. This is actually false. It is a extremely sinister entity. It requires immediate retransplantation. And hepatic arterial thrombosis, causes greater elevation of OTPT. It's also wrong. Portal vein thrombosis has a much more greater elevation of SGOT, SGPT than this entity. And regarding this, just look at this is again a trivia question. I'll not discuss this. This is not actually, this is with ALF. This is not this question. And these are all few trivial questions. Which of this one, anyone can volunteer. All of the following are compatible with the diagnosis of brain state except. So all of the following are compatible with the diagnosis of brain death. So which of the following features, if present, tells you that the patient's brain is functioning? Sweating, seizure, tachycardia, spinal reflexes, or absence of DI. Which of the following? Any volunteers? Which of the following are compatible with the diagnosis of brainstem death except? So the correct answer is seizures. So seizures indicate some viable portion of the brain is there. Otherwise, how would the seizure activity be occurring? Sweating can occur with spinal reflexes, tachycardia, spinal reflexes, absence of DI, not mandatory. They can be present with brainstem dead as well. But seizure negates brainstem dead. This one I'll again discuss during the brainstem discussion. So I'll quickly move on to the the discussion portion of it. Okay, so discussion I'll quickly finishing it. Okay. So okay, so this is the first. So brain death, for declaration of the brain death, you need to have you have to establish that your brain cerebrum and the brainstem both are non-functioning. So therefore, patient is bound to have coma, absent brainstem reflexes, and absence of carbon dioxide response to a elevated carbon dioxide tends to stimulate the respiratory center. So if your respiratory center is gone, then your CO2 response will not be there. That's what we are checking in the apnea test. There are some situations where drug poisoning, certain some disease states can mimic a brain death, like a snake bite, like neurological poisoning. If you're having a CNS depressant poisoning, like opioid overdosage, benzodiazepine overdosage, patient is having some neurological, like a atracunum infusion was going on. Now you, after 2 hours, you try to wake up the patient and see the response. The patient is invariably going to be E1M1 for everyone if the patient is already on 24 hours of atracunum infusion. So neuromuscular blocker overdosage. Then severe hyponatremia. The range is 110 to 160. Then severe hypokalemia to hyperkalemia. So hypokalemia is 3 to 6. So the one question was asked that can you do it at 3.1? Yes, 3.1 you can go ahead with apnea test. Less than 3 of potassium you cannot do. Severe hypo or hypercalcemia. And last but not the least, some disease like if you have a pontine hemorrhage or massive stroke with a locked-in syndrome. These are all high cervical spine injury like C5, C6. If you have a C5, C6 fracture, you cannot go with a apnea test. So these are the areas where this can mimic a brain dead situation and you cannot go with an apnea test. These are all confounders. And in cases of confounders, what you do is you can go ahead with the ancillary testing. As I said, one question was asked, triple flexion, that sometimes flexion of the hands, knees, and feet, everything happens. So that indicates a spinal reflex, not necessarily a brainstem. I mean, a functionality of the brainstem. Some lab criteria, just like I said, sodium, potassium, calcium, etc. Ammonia. If ammonia levels are more than 75, that also is a confounding factor for doing an apnea test itself. So in these cases, what you do, so this is a pathway you have to remember by heart. So that first of all, you stabilize the patient. Do not go for the rushing for declaring a brain dead, because this is a medico-legal term. You need to be very sure about the diagnosis. You need to involve as much as people as possible. So one MCQ was asked that can you, I mean, as an ICU team member solely declare brain dead? You cannot. You have to involve a neurologist or a neurosurgery resident, a neurosurgery person before declaring and document it. So first, manage the patient, establish, secure the airway, breathing, circulation, whatever is required. Look at the basic vitals. Look at the patient is already on fentanyl infusion or atracunum infusion. If there is a cerebral hemorrhage, look at the CT finding. If the CT or the MR is compatible with that of the patient's low GCS, and subsequently you see there is no confounding factors like these drugs and all these lab parameters, then only you go for an apnea test. Apnea test is a standardized test taken over 10 minutes. I'll discuss now. And if the apnea test is positive, we declare brain dead. Not only a single apnea test, you need to do it at least twice in UK and India after 6 hours. So the guidelines varies. In some countries, it is 4 hours apart, some countries 6 hours apart, and then declare brain dead. If the apnea test is inconclusive or you cannot do because of hypotension, arrhythmias, then I go ahead with the ancillary testing. That is best is the CT scintigraphy. And if the scintigraphy is not available, you can go for a CT perfusion and MR perfusion image. Here, one thing is coming up big time. not so important for you guys, that is transcranial Doppler, TCD. Transcranial Doppler is big time used in this particular area where to diagnose the diastolic blood flow. Some of the spinal reflexes quite common after brainstem donation, brainstem donor assessment or during the brainstem direct declaration. So you can have decerebrate posturing, fasciculation, sweating, Lazarus sign, repeated thumb movement, thumb up sign, and something known as a myokinia facial movement. So remember how you differentiate a spinal from a spinal reflex versus proper reflex. Spinal reflex is repeatable, bilaterally symmetrical, and you don't have cranial nerve reflexes on them. So cranial nerve will be absent, cranial nerve reflexes. Then only the spinal reflexes will be there. If the patient is grimacing, if the patient's cranial nerve are normal, pupillary reflex is there, you cannot go ahead with brainstem declaration. So it's not impossible. So cranial nerve reflex should be absent in spinal reflexes only to be present in these cases. EEG, you can do it, but if you have a drug poisoning, EEG can be misleading. So in those cases, you go ahead with the, as I said, your cerebral scintigraphy and all. You can read about the caloric test, that is the oculovestibular reflex test. 30 ml of cold saline 4 degrees into each ear, and after 2 minutes you check. After a minute you check the response of the pupils of the eyes, and you see the saccadic rhythm. That is the you check for the nystagmus, the first component, and you diagnose whether there is a brainstem functioning or not. So these are all very basic things. Regarding the apnea test, it is to be done after you have ruled out the confounding factors. Your patient is now relatively stable. If the patient is on NORAD, the NORAD dose is not getting escalated. The atracurium, whatever infusion you have stopped way back, for confirming, okay, this patient is out of the paralytic agent, you can do a TOF stimulation test, train of force stimulation. Particularly anesthesiologists are well aware of it. If you are not aware, just go read about TOF stimulation. That diagnoses whether the muscles are still paralyzed or not. After that, you go ahead with apnea test, where you first pre-oxygenate. The first step is to pre-oxygenate for 10 minutes, 100% oxygen. You measure the ABG, that is the PO2 and the PCO2. PCO2, the baseline is important. Even if your PCO2 is more than 50, you can go ahead if your delta PCO2 rise after the apnea is more than 20. So either the absolute rise to more than 60 or 20 rise, then the baseline is accepted as the positive for apnea test. Means the patient is brain dead or supposedly brain dead. And during this time, you have to keep on oxygenation. So you have to put a catheter, a nasal catheter inside the ET tube and oxygenate through that at 8 to 10 liters per minute. You can also connect it to a CPAP machine, just simple CPAP machine, and just turn on the CPAP. Don't give any breath. Now, most of our NIV ventilators have a backup mode, so that won't allow you. What you can do is that arrange a BiPAP, small BiPAP, connect to the oxygen, and keep a CPAP of keep 10 by 10. So that means a CPAP of 10, and just do the apnea test like that. Now, during this time, you can have various things. One is that spinal reflex. I've already told, don't need to be worried about it. If your patient has severe hypotension, you have to abort the test. If you have severe arrhythmias, you have to abort the test. While aborting, draw a blood sample. If your blood sample at say 6 minutes of apnea test is positive, your PCO2 is more than 20, baseline is more than 60, you have a diagnosis of apnea. So it is not that 10 minutes is sacrosanct. It is not that 10 minutes has to be there. If at 6 minutes you have done a blood, ABG, because patient was becoming hypotensive and that is positive for apnea, there is enough. And the thing is that if despite 10 minutes you see that PCO2 is not rising, what to do now? If you have that, okay, the patient is definitely brain dead, at 10 minutes PCO2 is not rising, you can continue with till the PCO2 rises. That is arbitrary, but you can continue. So the 10 minutes is variable. Organ donation criteria, various guidelines. I've already told that if you have a contained tumor, if you have a contained infection, you can pretty well go ahead and give it. But if the patient has a disseminated infection or the patient has an uncontrolled situation, then you cannot go for donation. For criteria for the organ donors is Maastricht criteria. There is a categories for it, 1 to 5. 1 and 2 are uncontrolled. 4 and category 3 is the controlled one. 3, 4 can be controlled, uncontrolled, and 5 is definitely uncontrolled. Depends on which scenario the patient's presents with. If the patient comes with an out of hospital cardiac arrest, unwitnessed, category 1. If the patient has unsuccessful resuscitation after the patient has come to the ED, that's category 2. But if the patient has gone into brain dead and after that patient has gone into cardiac arrest, that is basically category 3. That's what we are actually looking forward for organ procurement. And last but not the least is that category 5 is the new addition where cardiac arrest in hospital has also come, but that is also uncontrolled. What is control uncontrolled? Control means the patient's warm ischemia time is less, so the organs will be of better quality. Uncontrolled is that you don't know how much amount of time the patient was having a low perfusion state, so therefore patient's organs can be dicey. These are the physiological criteria to be maintained during an organ donation OT. So if the patient is on OT or harvesting the organs, keep the blood pressure in above map of 70 to 100, your CVP of 6 to 10. You should avoid pulmonary edema. You should keep adequate urine output, say 0.5 to 2 mils per kg per hour. You should avoid polyuria at more than 4. If it is going, you should avoid give desmopressin. So things like that you have to maintain. And management includes normalization of the blood pressure and hemodynamics. You in patients who are having a lung transplant, it is mandatory to do a bronchoscopy, go for a lung lavage before transplanting or harvesting it. Correct the acid electrolyte disbalance, correct the hormonal disbalances. For hormonal disbalances, what you do is that you should go for the initially what happens immediately after the organ donation, organ procurement or brain death is that there is immediate catecholamine stone. Entire brain gives off its entire supply of the catechol within a few minutes, and that goes to the system, and that causes tremendous rise in the heart rate and the blood pressure, and therefore there is an initial surge of catechol stored, causing hypertension, tachycardia, arrhythmias, even MI, that is known as the neurogenic cardiogenic pulmonary edema, neurogenic edema, pulmonary edema, and heart failure. But afterwards, once the stores are depleted, they go into a severe vasoplegic state. And this severe vasoplegic state is where you have to go for the hormonal therapy and vasopressors. So in these cases, we have to choose vasopressin whenever the patients are not responding to standard fluid therapy. You have to go for steroids and thyroxine supplementation. Thyroxine is now losing its importance nowadays, as I have said. And steroids, still it is now usage. Either you give hydrocodone or methylprednisolone, neither is okay. And organ harvest time, not so important, but important. The warm ischemia time, cold ischemia time, that concept wise very important. Liver transplant, I'm just go to this important concept that if the patient is having a liver transplant, and few things. First of all, liver transplant, post liver transplant, what to monitor, and how do you say that the patient is having a graft function which is not adequate. One is that persistently raised transaminitis beyond 24-48 hours. Persistence of coagulopathy, raised INR beyond say 2.5 or 3 after 48 hours. Persistence of hypocalcemia, raised lactic acidosis, persistent hypoglycemia. All this indicates that the liver is not working function normally, that the toxin removal effect is not adequate, and therefore you can have problems. So, severe persistent organ dysfunction, coagulopathy, hypocalcemia, these are all important things to consider. Approach to patient. Now this one's actually based on a question which I've removed it. So this is a scenario where a patient post liver transplant has come to you or 48 hours of transplant, and you see that there is some derangement of the liver function. The OTPT is deranged, and patient is having coagulopathy. So in that cases, how to approach these cases? So in this case, you have to look out for the causes. So cause of a post-transplant liver failure could be a vascular, could be graft itself, or could be biliary. Now, biliary complications occur more than 7 days into the transplant. Generally, when you remove the T tube, that is the connecting tubing between the bile ducts, then only it happens. Immediately, what happens is vascular complications. So, liver has an inflow and outflow. Inflow is by the hepatic artery, portal vein, and the outflow is by the hepatic veins. So if you have a hepatic artery thrombosis, portal venous thrombosis, or you have a hepatic venous outflow obstruction, these are all causes of vascular causes of liver failure. Graft dysfunction mostly can be a primary graft dysfunction, or it could be antibody mediated graft dysfunction, or mostly the antibody mediated rejection. Rejection, cellular rejection or organ rejection could be various ways. So key concerns, looking at the timetable, the immediate concerns are vascular or immediate rejection because of the hyper rejection type, or it could be other metabolic problems. You can have a pleural effusion, ascites, etc. Those keep on happening. Later on complication could be immunosuppression induced complications, cardiac complications, etc. So patient coming to you with sick-like situation, you should first manage the patient, conservatively. You should do a INR and APTT monitoring and do a TEG if you suspect bleeding, and TEG guided administration of different products. Like if you have, severely reduced platelet functioning, you give platelets. If you have a platelet fibrinogen assembly dysfunction, you should give cryoprecipitate. And in cases of active bleeding, you can give PCC as well. So different things you can give. And if you have a prolonged fibrinolysis, you can give for antifibrinolytic therapy. So platelets and different blood product transfusion only if there is a bleeding, because these patients have a balance of coagulation. So they have a hyperproliferation, hypercoagulable and hypercoagulable state coexistent. So don't give products blindly. And afterwards, what is more important to remember is that different types of graft malfunction. So one is that PNF. One question was asked that patient post transplant has PNF. Straightforward, go for detransplant or the patient is going to die. 100% mortality. Diagnosed with very high levels of AST/ALT and INR levels, and lactate levels are high also, and pH severe acidosis indicates that the graft is just not functioning. It's primary non-function of the graft. And there is something known as EAT, early allograft malfunction, that is correct diagnosed by something known as a Othof's criteria, which is having AST/ALT levels of more than 2000, bilirubin more than 10, and INR more than 1.6. Don't need to mug up this entire criteria. We're not going to come, but at least know the primary non-function, straightforward detransplant, early allograft functioning. You can go for supportive care, like plasmapheresis, etc. And then you go for transplant if not responding. Rejection could be hyperacute, acute, and antibody mediated, and could be chronic. Hyperacute is mostly vascular or mostly preformed antibodies. So if you have a preformed antibodies because of less mismatch or some previous transfusion which has led to the recipient having some donor antibodies against the donor cells, that cause an hyperacute rejection within minutes to days. Acute generally starts off within weeks, and it is diagnosed based on the histopathology findings. So you do a liver biopsy to diagnose, and chronic is usually takes years. Chronic we are not so much worried about. And acute rejection is usually immunity mediated, and it can have two types. One is cellular rejection, and one could be antibody mediated. So it could be that cellular rejection is mediated by T cells. In those cases, we have to go for CNIs, that is the calcineurin inhibitors and steroids. And antibody mediated rejection is usually because of B cell hyperproduction of antibodies. In those cases, you have to go for ATG, anti B cell agents, steroids, ATG, and tacrolimus are the mainstay of treatment. Coming to the last part of this topic is that the vascular complications after liver transplant is mostly hepatic artery thrombosis, portal venous thrombosis, and splenic artery steal phenomena. These are the three. Just one line I'll go about each of them. Hepatic artery thrombosis most common. It can happen in 5 to 10% cases. It is associated with modest elevation of AST/ALT. How to remember? Your portal vein supplies 70% of liver and hepatic artery 30% of liver. So portal vein obstruction will have more severe necrosis and more elevation of AST/ALT as compared to hepatic artery. So hepatic artery occlusion will cause around 1000 to 2000 level of AST/ALT, but in portal venous occlusion is usually higher. The treatment for them and the causes for them are almost similar. It could be a surgical kink, it could be some malfunction, anastomotic failure, could be thrombus. So you do an ultrasound to diagnose them. Not going to the details how you diagnose individual entities, but you have to diagnose those based on a bedside ultrasound, and you have to call an intervention radiologist if they can move the clots, if they can. Otherwise, they will go for detransplant in the direst of cases. Splenic artery seal phenomena is when you have a properly functioning graft, but you see suddenly splenomegaly happening, and put a Doppler on the spinal artery flow velocity. You see that the splenic artery is having higher peak systolic velocity, and that indicates that the patient's blood supply from the superior mesenteric portal vein is actually getting diverted to splenic vein and not to the portal vein into the liver, and therefore you have a hypoxemia of the liver. So that is how you diagnose them. Biliary complication, as I said, is a late complication more than 7 weeks after the transplant. Management, infection and all, these are mostly you can gauge. And one last thing, slide, which is important. This is the main important slide, which is very important to remember. Post-transplant, less than a month, all the opportunistic infections of the hospital like VRE, vancomycin-resistant enterococcus, MRSA, streptococcus, pseudomonas, enterobacterial serratia, stenotropomonas, all these hospital-acquired pathogens are mostly important for the less than a month period. Whereas 1 to 6 months period, we're looking at opportunistic infection like PCP, VZP, adenovirus infections, reactivation of tuberculosis, MAC infections. And if the patient is on cotrimoxazole, then PCP obviously is a rarity. Then you should think about other things as well. More than 6 months, you're looking at community acquired. So if the one question was asked, patient is coming with CAP immunocompromised 2 months, you should go for the CAP cover along with the cover for PCP and CMP and look for it. For in order to diagnose them, you should go for an HRCT scan to look for the different patterns. That's it. I'm not going to the details of individual things. So that's done for this today's class. Any question, final comments or final questions? Any questions? Or we can I can call it a day. It was supposed to be a 1 hour, 1 and 15 minute session, but it went all to 1 hour 45 minutes, it seems. Any clarification from anyone's side? Okay, I guess. Okay, then I think we'll call it a day. Fatma.
Yes, sir. So thank you for being with us, and thank you all the students. Tomorrow the crash course session will start from 3 p.m. Okay, and from that only it will go. And I will keep informing everyone about the classes and their timings. Thank you.
Just one word, apologies again for the bad connection. And if anyone has any doubt, they can email or contact the administrator, and they can reach out to me. I'm happy to answer any queries. Thank you.